Good afternoon, everyone. My name is Dalia El-Mafti, and I'm an assistant professor at the University of Chicago. And today we'll be talking about pain management and painful disease states. I have no financial disclosures to disclaim. Hopefully by the end of this presentation, you'll become more familiar with some of the pain pathophysiology and definitions. You'll be more aware of some of the painful disease states, as well as some of the treatment modalities that we use. Pain pathophysiology and taxonomy. What is pain? Well, pain does not necessarily mean nociception. Pain, as defined by the International Association for the Study of Pain, is an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage. Nociception is actually the process in which we detect and signal a noxious stimuli. When we refer to pain, we usually describe it either as acute pain versus chronic pain. Acute pain sometimes is defined by the duration. For the most part, acute pain is considered short duration and resolves once tissue has healed. So it does have a defined recovery time period. There is no actual insult to the pain processing system, so it's considered that the nervous system is usually intact, and it can be caused by multiple etiology. It can be related to trauma, to surgery, or acute medical conditions, for example, myocardial infarction and anginal pain, or from a physiological process such as labor. With acute pain, it sometimes can be associated with neuroendocrine stress response, and by that I mean there can be hemodynamic effects that can be present. Examples of some of the hemodynamic effects that can be seen, but not necessarily required to be seen with acute pain, is tachycardia, hypertension. Sometimes patients can become very diaphoretic. It can also be associated with splinting, where we have a fast, or tachypnea, fast respiratory rate with reduced tidal volumes. Sometimes you can also see facial grimacing. It can be associated with anxiety, confusion, and some of our elderly population delirium. There can also be decreased intestinal motility, which can obviously lead to constipation, and also increased sphincter tone, which can result in urinary retention. Chronic pain, on the other hand, can also be defined according to the timeline. There's some controversy regarding the exact definition of chronic pain, but it can be pain that persists anywhere from 3 to 6 months after the initial insult. With chronic pain, there is an insult to the nervous system. And what I mean by that, there's plasticity of the nervous system and pain processing. There are multiple causes of chronic pain. Amongst them are degenerative disease, neoplastic in nature, sometimes trauma, and other inflammatory processes. With chronic pain, there are some associated findings. For the most part, there's adaptation of the neuroendocrine response, so you won't necessarily see the hypertension, the tachycardia that you may have seen with acute pain, but there's an emergence of certain psychosocial responses, meaning there can be mood disorders, depression, anxiety, decreased desire to socialize. Patients can have sleep deprivation as well. Well, I have a question here. An otherwise healthy 58-year-old man has a sudden onset of sharp pain in the lateral aspect of his left femur. Subsequent radiographic imaging demonstrates a left femur fracture. What type of pain is the man describing? Is it A, visceral pain, B, somatic pain, C, neuropathic pain, or D, central pain? So the correct answer is B, somatic pain. And we'll go on as the presentation proceeds for you to understand why B, somatic pain was the correct answer. Now, as I go through this presentation, there's going to be a series of questions, and those questions are going to lead us into the next topic. But as I mentioned earlier, nociception does not equal pain. Nociception is the process where we detect and signal pain. There is a type of pain which is considered nociceptive pain. And basically what that means is pain that is mediated through nociceptors. Now our nociceptors are high threshold receptors, usually free nerve endings, that can detect a noxious stimuli. Most of the times nociceptive pain is responsive to opioids. And when we refer to nociceptive pain, there's two forms. There's somatic and visceral. When we refer to somatic pain, that's usually pain that's associated with nociceptors that can be found in the skin, the muscle, tendons, and fascia. When we refer to nociceptive pain that's visceral origin, that usually means nociceptors that can be found on internal organs. Each of these have a different character and quality based on the symptoms. With somatic pain, it's usually very well localized, and sometimes it can follow nerve distribution. Oftentimes patients define it as a sharp pain. With visceral pain, it tends to be very diffuse. A lot of patients will describe it as aching or burning in sensation. Visceral pain usually often is a referred type of pain. Other types of pain are neuropathic in nature. Neuropathic pain, again as defined by the International Association for the Study of Pain, is pain caused by an injury to the somatosensory system, whether it be the peripheral nervous system or the central nervous system. Oftentimes, it can lead to central sensitization, and the N-methyl D-aspartate receptor has been implicated in this type of pain. Patients will have a vague description of symptomatology. It can range anywhere from feeling burning sensation, tingling, shooting, or electric-like pain. Oftentimes, this type of pain is resistant to opioids. Later on in the presentation, we'll be talking about different types of neuropathic pain. Okay. Another question that we have. A 26-year-old woman presents with a 3 months history of pain throughout her left arm, swelling and redness associated with that pain. She exhibits pain with even light touch on her arm. This symptom describes, or this sign describes, which of the following below? A, allodynia. B, anesthesia dolorosa. C, hyperalgesia. Or D, neuropathic pain. The correct answer is allodynia, A. Anesthesia dolorosa refers to pain or spontaneous pain that occurs in an area that is anesthetic, meaning has no sensation. C, hyperalgesia, is an increased response to a stimuli that's not normally painful, while D, as we mentioned earlier, is pain that is caused by a lesion in the somatosensory nervous system, whether it be the peripheral or the central nervous system. There's certain terminology and definitions that is important for you to understand as we talk about pain pathophysiology and pain in general. Allodynia, as we discussed earlier, is a pain that is caused by a non-noxious stimuli. An example of that is somebody placing a bed sheet over their arm and that causing severe pain. Hyperesthesia is increased pain to a mild stimuli. Hyperalgesia is increased pain to a painful stimuli, and hyperpathia could be any one of these. It could be allodynia, hyperesthesia, or hyperalgesia. But basically, it's an overreaction to a painful stimuli or a non-painful stimuli. This is a table that can help you understand some of the terminology that's used as we describe certain symptoms and signs and pain. On the left-hand side are the terms allodynia, hyperesthesia, or hypoalgesia. In the middle is the stimuli, and to the right is response. So if you look at the table below, 1 is a weakest stimuli, where 5 is the strongest stimuli. So in a normal pain processing, if you give a normal stimuli, you should have a normal response. In patients who have allodynia, if you give a weak stimuli, you have an exaggerated or a stronger response. With hyperesthesia, you give a strong stimuli and you get an even stronger response. With hypoalgesia, you give a strong stimuli, but you get a weak response. Some other terms that you may hear when talking about pain pathophysiology and etiologies: anesthesia dolorosa, as we mentioned before. It's pain that occurs in an area that's anesthetized. An example of that is a patient who might be paraplegic, who has complete sensory and motor loss, yet they still feel this ongoing burning sensation in their lower extremities. Paresthesia is usually defined as an abnormal sensation, whether it be spontaneous or evoked. Dysesthesias are unpleasant abnormal sensations. An example of that would be a patient who tells you they feel like they have spiders crawling on their arms. Neuralgia is pain in the distribution of the nerve. Neuritis is the actual inflammation of a nerve. So an example of that would be optic neuritis. Radiculopathy is a functional abnormality in one or more nerves, and that's often associated with back pathology, whether it be cervical, thoracic, or lumbar degeneration, and we'll discuss that later in the presentation. We're now going to shift our talk to different types of painful disease states. Earlier, we talked about neuropathic pain, and we mentioned that neuropathic pain, again, is pain caused by a lesion in the somatosensory system. The lesion can take place in the peripheral nervous system or in the central nervous system. In the peripheral nervous system, some examples of neuropathic pain include diabetic peripheral neuropathy, phantom limb, postherpetic neuralgia, complex regional pain syndrome, or trigeminal neuralgia. Central types of neuropathic pain include post-stroke pain or spinal cord injury. Diabetic peripheral neuropathy. The exact mechanism in which it occurs isn't fully understood, but there is some literature that shows that it's caused by a microvascular injury or inflammation or metabolic byproducts that occur at the neuronal level. Oftentimes, the neuropathy can be reversible if we have strict glycemic control. Most patients who present with diabetic or diabetes, 4 to 8% of them will also present with peripheral neuropathy. By the time they are diabetic for 20 to 25 years, about 15 to 50% of them will have diabetic peripheral neuropathy. Well, what do the patients present with? They usually come in with a glove and stocking pattern distribution of pain. Oftentimes they can report certain sensory disturbances. They can report burning sensation in bilateral hands or feet. They can also report allodynia or different types of paresthesias that occur in the hands or feet. On exam, they may have diminished reflexes. They may also have loss of proprioception and vibratory sensation. What's the treatment of diabetic peripheral neuropathy? Like most of our pain syndromes, we're going to emphasize the concept of multimodal therapy. But there are some guidelines out there that are published that help practitioners treat different types of neuropathy. The Canadian Pain Society, the European Federation of Neurological Society, and the International Association of Study of Pain have published guidelines on treatment of peripheral neuropathy, and they classify management into first line, second line, and third line treatments. Most of the first line treatments include some of our membrane stabilizers, otherwise known as anti-epileptic drugs, and our antidepressants, such as our tricyclic antidepressants and our selective norepinephrine and serotonin reuptake inhibitors. Again, we'll talk about this a little later in the presentation as we talk about treatment modalities. Unfortunately, the ultimate treatment for some of these patients which have severe diabetic neuropathy may lead to amputation if the disease isn't treated appropriately. Phantom limb pain. As we mentioned that some of our diabetic patients may end up resulting in an amputation. Amputation itself is not the cure and can actually lead to a chronic disease state known as phantom limb. And basically what that means is that the patients have an unpleasant sensation in the distribution of the missing body part. Stump pain can also occur after amputation, and that basically is an unpleasant sensation in the body part that is left. About 50 to 80% of our amputees can develop phantom limb pain. It's more severe when the amputation is more distal. It can present anytime from 1 week post-amputation up to 40 years post-amputation. Again, as many of our neuropathic pain syndromes, the mechanism is unclear. There is thought that it has to do with plasticity that can occur at the level of the brain, spinal cord, or peripheral nerves. Treatment is also quite difficult. Many of our neuropathic pain syndrome, even with medication management, patients still report moderate to severe pain. Once again, a multidisciplinary approach is going to be recommended, and we're going to discuss some of those modalities later on. But once again, medications, non-pharmacological methods, and neuromodulation is usually recommended. There are certain factors that can influence the presentation or the development of phantom pain. There are certain internal factors that are related to the patient and external factors that might be related to the perioperative time frame when the amputation occurs. But with chronic pain syndromes in general, patients that have pre-existing pain are more prone to developing chronic pain and phantom limb, as well as patients that have high anxiety prior to the surgery or catastrophize about the surgery. There's literature that shows that they have a higher incidence of developing phantom limb pain, certain genetic predispositions as well. External factors that can modify the development of phantom limb pain, well, the whole concept of preemptive analgesia, meaning treating pain before it actually presents, is important, especially in these types of disease states. Performing regional or neuraxial techniques, and we'll discuss that later. But after the amputation, rehabilitation is extremely important, getting the patients into physical therapy and actively participating. Desensitization of the stump, basically just by touching the stump, can actually reduce the incidence of developing phantom limb, because once again we're re-educating the nervous system about normal sensation versus abnormal sensation. Wearing the prosthetic and ambulating can also help improve or decrease the incidence of phantom limb. Okay, this question will take us into our next painful disease state. A 78-year-old female with congestive heart failure presents with a 4-month history of chronic chest wall pain following an episode of shingles. All the following medications have demonstrated benefit except A, nortriptyline, B, transdermal capsaicin, C, gabapentin, D, duloxetine, or E, diclofenac. Correct answer is E, diclofenac. Diclofenac is a non-selective, non-steroidal anti-inflammatory drug, and unfortunately the literature has not shown it to be effective in the treatment of postherpetic neuralgia. So what is postherpetic neuralgia? It as well is a type of neuropathic pain. It commonly occurs in our elderly population at times of stress or immunocompromise. It is due to the reactivation of the varicella-zoster virus. Oftentimes, patients will complain of burning pain, rarely electric shooting pain in the dermatomal distribution, meaning it will follow a certain nerve route, whether it be the T7, T12 intercostal nerve, or sometimes also affecting facial and the distribution of the trigeminal nerve. As most of our neuropathic pain states, it's very much refractory to opioids. And treatment recommendations include using our anti-epileptic drugs and our antidepressants, as well as some topical agents. There is some literature out there that shows preemptive measures, meaning vaccination, may also help reduce the incidence of developing postherpetic neuralgia. Now, postherpetic neuralgia is different than acute pain from herpes zoster, and basically patients who have acute pain from herpes zoster, this usually occurs around the time of the rash, and that pain is usually described as being sharp in nature and also electrical shooting. Treatment modalities tend to be similar to that of postherpetic neuralgia. Next question. A 26-year-old female presents with a 3-month history of pain throughout her left arm associated with swelling and redness. She has not seen benefit from medications and is unable to actively participate in physical therapies secondary to her severe pain. The appropriate next step is most likely a fluoroscopy-guided block anterior to the aorta at the level of T12, vertebral body, or L1, or B, a fluoroscopic-guided left-sided block at the anterior lateral border of the L3 vertebral body, C, infiltration of local anesthetic along the posterior border of the sternocleidomastoid muscle, or D, fluoroscopic-guided left-sided injection of local anesthetic along the anterior border of the C6 tubercle. The correct answer is D. Basically, that is what we refer to as a stellate ganglion block, and it's indicated in patients who have complex regional pain syndrome of the upper extremity. A refers to a celiac plexus block. Actually, the T12 block performed at the T12 level is considered a splenic nerve block, while a block at the L1 level is a celiac plexus block. B refers to a lumbar sympathetic block, which is a block also performed from patients who have complex regional pain syndrome, but of the lower extremity, and that's performed at the anterior lateral border of the L3 vertebral body. C basically explains or describes a superficial cervical plexus block. So that leads us into the disease state of complex regional pain syndrome. Now, this disease tends to be quite a challenge both for patients and the physician. Most important thing when diagnosing complex regional pain syndrome is to make sure and exclude any other possible etiologies or pathological states. About maybe 10 years ago, a group of experts in pain management came together to help develop a criteria to help physicians identify patients who have complex regional pain syndrome by classifying certain symptoms and signs, again, that can help diagnose CRPS. One of the most important things in patients who have complex regional pain syndrome is to keep that extremity active and functional, because they can quickly lose range of motion and strength, which can result into disuse atrophy if that extremity does not remain functional. As many of our neuropathic pain states, again, we use a multimodal approach, as well using antidepressants, antiepileptics. With complex regional pain syndrome, there are some additional medications that may be beneficial. There's some literature regarding ketamine infusions, and we'll talk about that in a little bit. Interventional procedures can be considered. Sympathetic blocks, such as the stellate or the lumbar sympathetic block, can be performed, as well as other neuromodulation techniques, such as spinal cord stimulation. This will be discussed further in just a bit. How do we classify complex regional pain syndrome? Well, the International Association of Study of Pain defines it either as CRPS type 1 or CRPS type 2. CRPS type 1 basically occurs when there is no trauma to a nerve, but a noxious event may have occurred. The old term for it used to be reflex sympathetic dystrophy, otherwise known as RSD. Where CRPS type 2 usually results after a nerve has been injured. The old term for it used to be causalgia. What is the Budapest criteria I was referring to? Well, again, it's a series of symptoms and signs. Usually, to be diagnosed with CRPS, you have to have at least one symptom in 3 of the categories or one sign in 2 of the categories. Well, what are these symptoms and signs? Patients who have complex regional pain syndrome, otherwise known as CRPS, can present with allodynia. We talked about allodynia earlier, and that's basically a non-painful stimuli which is perceived as painful. Once again, a fan blowing on an extremity or a sheet being rubbed up against the extremity that's diseased. Patients also may present with hyperalgesia to pinprick. Yes, a pinprick is painful, but they give an exaggerated response to it where it can cause excruciating pain. There are some vasomotor symptoms and signs that can be present. There is some implication of the sympathetic system being involved with this disease process, and one can note temperature changes or asymmetry between the limbs. Meaning there can be a greater than 1 degree temperature difference between, for example, if you had CRPS of the right upper extremity, it could be colder than the left extremity. Skin changes can occur, color changes, modeling of the skin can occur as well. There are some pseudomotor changes that might be present, and what we refer by that is the extremity that's affected may have increased or decreased sweating compared to the other extremity. Certain motor or trophic changes can be seen in the extremity with CRPS. Tremors or dystonia can be visualized. And trophic changes, there may be decreased nail growth on the extremity that's diseased or decreased hair growth as well. And as we mentioned earlier, the treatment modality is multimodal. All right, move on to our next disease state. 59-year-old female presents with a 3-week history of pain, paroxysmal pain, that lasts less than 1 minute in her right face and extends into her gums and teeth. The pain is provoked when she applies makeup. On physical exam, she looks within normal. What is the most appropriate first-line therapy for this female? A, radiofrequency ablation of the sphenopalatine ganglion. B, carbamazepine 100 milligrams twice a day. C, nortriptyline 75 milligrams every evening. Or D, interferon B1A 30 milligrams intramuscular once a week. The correct answer is B, carbamazepine. What this patient is presenting with is trigeminal neuralgia, and that's usually considered, carbamazepine is considered first-line treatment for this pain disorder. A, sphenopalatine ganglion block, that's usually not considered first-line treatment for trigeminal neuralgia, but can be considered treatment for other types of atypical facial pain. C, I believe was nortriptyline, which is a type of tricyclic antidepressant, and that is not the first-line treatment for trigeminal neuralgia. B, interferon is a treatment for multiple sclerosis. So what is trigeminal neuralgia? Well, it is a rare neurological disorder, and the incidence has been reported to be anywhere from 2 to 26 per 100,000. It tends to be more common in female than males. It usually occurs at the age of 50 to 80, and it tends to be caused by a vascular compression of the trigeminal nerve at the level of the brainstem or distally to it. There are 2 types of trigeminal neuralgia. One is referred to classic trigeminal neuralgia, and the second is considered symptomatic trigeminal neuralgia. Symptomatic trigeminal neuralgia basically means if there is a structural lesion other than vascular compression that has been identified, such as a tumor. One of the most important things with trigeminal neuralgia, again, is that it has to fit within the diagnostic criteria that helps define it. In order for the disease to be considered trigeminal neuralgia, patients should report paroxysmal attacks of pain that last anywhere from seconds up to 2 minutes, and it can affect one or more branches of the trigeminal nerve. You also have to include either criteria B or C, where criteria B basically is pain that lasts pain that has at least one of the following characters, which is intense, sharp pain. It can be triggered by certain trigger factors, such as brushing the face, brushing your teeth, drinking cold water. The attacks are usually stereotyped for that individual patient. Basically, the patient will tell you that every time I, have attacks of my trigeminal neuralgia, I get a sharp shooting pain along the lower part of my jaw, and it can be triggered by me drinking cold water. Again, there isn't any clinically evident neurological deficits that can be identified. Once again, treatment modalities, multimodal treatment modalities. First-line treatment for trigeminal neuralgia is carbamazepine. Other treatment modalities include baclofen and lamotrigine. With carbamazepine, you have to be very cautious when initiating this medication in patients. It does have some rare side effects that can occur, and patients have to be followed with blood work. It can cause aplastic anemia and hyponatremia, so that's why CBC is indicated, as well as checking sodium levels. It is metabolized by the liver, so making sure LFTs are appropriate is indicated as well, or liver function tests. Some of the interventional treatment options for trigeminal neuralgia if medication management fails includes microvascular decompression, and that's basically indicated for situations when there's vascular compression of the nerve, which occurs in classic trigeminal neuralgia. Other interventional modalities include gamma knife, laser, radiofrequency ablation of the Gasserian ganglion as well as indicated.